Glaucoma, the silent progression. Welcome everyone. Today we are going to explore one of the most important yet overlooked causes of irreversible blindness worldwide, that is glaucoma. It is commonly called the silent thief of sight because vision loss develops gradually and painlessly in many patients. Most individuals may not even realize the damage is occurring until significant and permanent vision loss has already taken place. In this lecture, we will understand the mechanisms behind glaucoma, how it progressively damages the optic nerve, methods for early detection, and principles of clinical management used to preserve vision. The image shown here represents the optic disc and retinal nerve structures inside the eye. Normally, the optic nerve carries visual information from the retina to the brain. Within the optic disc, there is a small central depression known as the physiological cup surrounded by the healthy neuroretinal rim. In glaucoma, IOP pressure, that is intraocular pressure, and the other pathological mechanisms gradually damage the retinal ganglion cells and the optic nerve fibers. Over time, the optic cup enlarges, the neuroretinal rim becomes thinner, and visual field defect begins to develop. One of the greatest challenges in glaucoma management is that early disease is often asymptomatic. Patients may continue daily activities normally while progressive peripheral vision loss silently occurs in the background. That is why early diagnosis through regular eye examinations, optic nerve evaluation, tonometry, and visual field testing is extremely critical. Throughout this session, we will cover types of glaucoma, pathophysiology, and optic nerve damage, risk factors, clinical presentation, diagnostic investigations, pharmacological and surgical management, and the strategies for preventing irreversible blindness. This lecture is designed for medical students, NEET PG aspirants, healthcare learners, and anyone interested in understanding eye health and glaucoma progression in a simplified yet clinically detailed way. So let's begin our journey into understanding glaucoma, the silent progression of vision loss. The global burden of glaucoma. Before we understand the clinical signs of glaucoma, it is important to recognize the enormous global impact of this disease. Today, more than 80 million people worldwide are living with glaucoma. This makes it one of the most significant chronic eye diseases affecting public health across the globe. But perhaps the most alarming fact is that nearly 50% of the individuals with glaucoma are completely unaware that they have it. Why? Because glaucoma often progresses silently. In the early stages, most patients experience no pain, no redness, and no obvious symptoms. Central vision may remain normal, while the peripheral vision slowly deteriorates in the background. The vision shown here demonstrates this concept of silent peripheral vision loss. Gradually, the outer visual field begins to disappear due to the progressive optic nerve damage. By that time, patients noticed substantial and irreversible injury may already have been occurred. That is why glaucoma is called the silent thief of sight. Globally, glaucoma is considered the second leading cause of blindness. Unlike some other eye conditions, the vision loss caused by glaucoma cannot once optic nerve fibers are destroyed. This is one of the most important concepts to remember. Glaucoma-related blindness is irreversible. Treatment can slow progression and preserve remaining vision, but it cannot regenerate the damaged optic nerve tissue or recover lost visual. That's why early detection becomes absolutely critical. Routine eye examinations, intraocular pressure measurements, optic disc evaluation, and visual field testing allows clinicians to identify the glaucoma before severe damage develops. Certain populations are especially at risk, including individuals, patients with family history of glaucoma, people with diabetes or hypertension, individuals using long-term corticosteroids, and populations with elevated intraocular pressure. The key message is simple but powerful. Glaucoma, but it is frequently undiagnosed and permanently vision threatening, but early diagnosis can prevent blindness. Awareness and screening are therefore some of the strongest tools we have in protecting vision and reducing the global burden of glaucoma. Clinical case introduction. Now let's move from theory into a real clinical scenario to understand how glaucoma presents in actual practice. This slide introduces a patient profile with classic features suggestive of primary open-angle glaucoma. Our patient is Mr. Krishnamurthy Iyer, a 62-year-old retired teacher from Chennai. His chief complaint is very important and highly characteristic. He reports that for nearly 2 years he has been bumping into objects from the side. This seemingly simple complaint is actually a major clinical clue pointing towards progressive peripheral visual field loss, one of the hallmark features of glaucoma. Notice that the patient does not complain of pain or sudden blindness. Instead, the symptoms are gradual and subtle, which is why glaucoma often remains undiagnosed until significant optic nerve damage has already occurred. Now let's examine his risk factors. The patient has type 2 diabetes mellitus for 12 years and significant myopia with a refractive error of minus 4.5 diopters. His blood pressure is moderately elevated as well. These findings are clinically relevant because advanced age, diabetes, and moderate to high myopia are all recognized risk factors for glaucoma progression. Now moving to clinical findings. The intraocular pressure or IOP is markedly elevated. 32 milliliters of mercury in the right eye and 28 milliliters of mercury in the left eye. Remember, the normal IOP range is approximately 10 to 21 milliliters of mercury. Elevated pressure increases mechanical stress on the optic nerve head and contributes to the retinal ganglion cell damage. Next is the cup to disc ratio, also called the CDR. The patient has a cup disc ratio of 0.8 in both eyes. Normally, the cup disc ratio is less than or equal to 0.6. An enlarged cup disc ratio suggests glaucomatous optic nerve cupping due to the progressive loss of the neuroretinal rim tissue. The visual field test further supports the diagnosis. The patient demonstrates an accurate scomatoma with a superior nasal step, classic glaucomatous visual field defects caused by the damage to the retinal nerve fiber bundles. Putting all these findings together, the patient has multiple major glaucoma risk factors: elevated IOP, age above 60 years, significant myopia, diabetes mellitus, and probable unassessed family history. This case perfectly illustrates how glaucoma develops silently over time before patients finally notice functional visual impairment. The major lesson is that subtle peripheral vision complaints combined with the elevated IOP, optic disc cupping, and characteristic visual field defects should immediately raise suspicion for glaucoma. Early recognition of these warning signs is critical because timely intervention can preserve remaining vision and slow irreversible optic nerve damage. Why early examinations matter. Now let's look at one of the most important real world lessons in glaucoma prevention: the timing of eye examinations. This slide presents a common clinical scenario. Imagine a 55-year-old individual who is mildly myopic, diabetic, and currently has normal reading vision. At first glance, the person feels completely healthy and may believe that an eye examination is unnecessary. But glaucoma does not wait for symptoms. The first pathway shown here represents a very dangerous misconception. I will wait until my vision becomes blurry. This is one of the biggest mistakes patients make. In glaucoma, central vision is often preserved until the late stages of disease. Patients can continue reading, recognizing faces, and performing daily activities while peripheral optic nerve damage silently progresses in the background. By the time reading vision becomes blurred, severe, and irreversible, functional blindness may already be approaching. The second pathway demonstrates another common issue: delayed follow up. A patient may think, I had an eye checkup at 50, so I will go again at 55. Unfortunately, glaucoma progression can occur silently during these missed years. Small visual field defects, known as the scotomas, may gradually enlarge without the patient noticing any symptoms. This creates a missed clinical window. a period during which clinical intervention and early intervention could have prevented permanent optic nerve damage. Now, look at the third pathway, which represents the ideal preventive approach. A patient with diabetes, myopia, and age above 50 recognizes their risk factors and undergoes annual eye examinations. During routine screening, elevated IOP spikes are detected early, while vision remains completely normal at 20 or 20 because the disease is identified before significant optic nerve injury develops. Treatment can begin immediately and functional vision can be preserved. This is the true power of screening and preventive ophthalmology. The key message is that glaucoma screening should be risk based, not symptom based. Patients with diabetes, myopia, hypertension, family history of glaucoma, steroid use, or age above 40 to 50 years require regular comprehensive eye examinations even when vision appears normal. Remember this crucial principle. In glaucoma, absence of symptoms does not mean absence of disease. Early detection is often the difference between preserved vision and irreversible blindness. Progression of vision loss in glaucoma. Now let's visualize how glaucoma silently progresses over time and why so many patients remain unaware until late stages of disease. The first image presents the normal vision. In a healthy eye, both central and peripheral vision remains intact, allowing full awareness of the surrounding environment. As glaucoma begins to develop, the earliest changes occur in the peripheral visual field. In the second stage, shown as slight peripheral dimming during the first 1 to 3 years, retinal ganglion cells gradually begin to die due to chronic optic nerve damage, often caused by elevated IOP. This process is extremely slow and painless. On average, untreated glaucoma may lead to loss of 1 or 2% of retinal ganglion cells every year, and most importantly, these nerve cells do not regenerate. Now, here comes one of the most fascinating and dangerous aspects of glaucoma. The brain itself hides the disease. As peripheral vision narrows, the brain actively fills in the missing visual information using surrounding visual cues. Because of this neurological compensation, patients may continue functioning normally without realizing that the portions of their visual field are disappearing. This is why many patients remain asymptomatic during the early stage and moderate stages of glaucoma. In the third stage, occurring approximately between years 4 to 7, noticeable backloss or peripheral visual field defects begin to appear. At this point, patients may start missing objects from the side, bumping into the furniture, having difficulty driving or struggling with the navigation in dim lighting. Unfortunately, by this time, these symptoms become noticeable, a major amount of irreversible optic nerve damage has already occurred. Studies suggest that the average patient may lose nearly 40% of optic nerve function over 6 to 10 years of silent disease progression before recognizing any visual deficit. This stage represents what many clinicians call the point of no return. Finally, in advanced glaucoma, severe tunnel vision develops. Only a small central island or vision remains while the surrounding visual field becomes completely dark. This significantly affects the mobility, independence, reading ability, driving, and quality of life. If left untreated, the primary open angle glaucoma can eventually progress to legal blindness in a substantial proportion of patients over time. The key lesson is that glaucoma is not a sudden disease, it is a slow neurodegenerative process that silently destroys the vision over years while the brain masks the damage. This is what exactly why early screening, regular monitoring, and prompt treatment are so critical in preserving vision before irreversible loss occurs. Pathophysiology of glaucoma. How pressure damages the optic nerve. Now that we understand that how glaucoma silently progresses, let's examine the actual pathophysiology behind optic nerve damage. This slide explains one of the central mechanisms involved in glaucoma, the imbalance between aqueous humor production and drainage inside the eye. Think of the eye like a closed hydraulic system. At the front of the eye, the ciliary body continuously produces aqueous humor, a clear fluid that nourishes structures such as cornea and lens. Normally, this fluid is produced at a rate of approximately 2.5 microliters per minute. You can think of this process as a faucet continuously running. After being produced, the aqueous humor flows through the posterior chamber, passes around the iris, and enters the anterior chamber of the eye. From there, the fluid must drain out properly through a specialized structure called the trabecular meshwork, located near the angle between the cornea and the iris. This drainage pathway functions like a drain pipe. In many forms of glaucoma, especially primary open-angle glaucoma, resistance develops within the trabecular meshwork. As drainage becomes impaired, aqueous humor begins to accumulate inside the eye. Now imagine a faucet still running while the drain becomes partially blocked. Fluid pressure gradually builds up inside the system. This leads to elevated IOP. The pressure generated within the eye is then transmitted backward towards the optic nerve head located at the posterior portion of the eye, one of the most vulnerable regions in the lamina cribiosa, a delicate sieve-like structure through which optic nerve fibers pass. Elevated pressure compresses these nerve fibers and disrupts axonal transport, blood flow, and the cellular metabolism. Over time, this chronic mechanical and vascular stress triggers the apoptosis or programmed cell death of retinal ganglion cells. This is the key pathological event responsible for progressive glaucomatous optic neuropathy. As retinal ganglion cells die, the optic nerve gradually becomes excavated, producing the characteristic optic disc cupping seen during the fundoscopic examination. Importantly, glaucoma is irreversible because retinal ganglion cells in the human eye do not regenerate once destroyed. The entire process explains why lowering IOP remains the primary goal of glaucoma treatment. Whether through medications, laser therapy, or surgery, almost all glaucoma management strategies ultimate aim to either reduce the aqueous humor production, improve the aqueous drainage, or both. So the key takeaway is that glaucoma is essential, a chronic optic neuropathy caused by progressive retinal ganglion cell death, most commonly driven by the impaired aqueous humor drainage and elevated IOP, that is intraocular pressure. Glaucoma diagnostic matrix. Now that we understand how glaucoma damages the optic nerve, let's compare the three major clinical types of glaucoma and understand how they differ in mechanism, presentation, and management. The diagnostic matrix summarizes the primary open angle glaucoma, primary angle closure glaucoma, and normal tension glaucoma. Let's begin with the primary open angle glaucoma or POAG. This is the most important common form of glaucoma worldwide, accounting for nearly 70% of the cases. In India, the prevalence increases significantly after the age of 40. In POAG, the drainage angle between the cornea and iris remains anatomically open, but the trabecular meshwork gradually loses efficacy over time. As a result, aqueous humor drainage slowly decreases, leading to progressive elevation of the IOP. The onset is usually insidious, painless, and asymptomatic during the early stages. Clinically, patients often show IOP greater than 21 milliliters of mercury along with increased cup disc ratio, usually above 0.6. The disease is commonly bilateral, although asymmetry between the two eyes is frequent. Now let's move to PACG, that is primary angle closure glaucoma. Unlike POAG, this form develops the sudden physical obstruction of the drainage angle itself. This creates a true ophthalmic emergency because aqueous humor outflow becomes blocked, causing rapid and dramatic elevation of the IOP. PACG is seen more commonly in Asian and Indian populations as well as in hypermetropic individuals with anatomically narrow anterior chamber angles. Clinically, patients present with severe eye pain, headache, nausea, vomiting, colored halos around lights, blurred vision, corneal edema, and a fixed mid-dilated pupil. This is a medical emergency requiring immediate treatment to prevent permanent vision loss. Acute management commonly includes pilocarpine to constrict the pupil and intravenous acetazolamide to rapidly reduce the IOP. Now let's discuss the normal tension glaucoma, that is NTG. This condition is particularly interesting because glaucomatous optic nerve damage, even though occurs in the IOP, remains within the normal range, typically less than or equal to 21 milliliters of mercury. This suggests that factors beyond pressure alone contribute to the optic nerve injury. Researchers believe vascular dysregulation, vasospasm, ischemia, and impaired optic nerve perfusion may play major roles. Normal tension glaucoma appears more commonly in women and Japanese populations. Clinically, these patients may demonstrate prominent optic disc hemorrhages and progressive visual field loss despite normal measured pressure levels. Management often requires aggressive neuroprotection and careful reduction of even normal range IOP. The key lesson is that glaucoma is not a single disease but a group of optic neuropathies with different mechanisms and clinical presentations. Primary open angle glaucoma progresses silently, angle closure glaucoma presents dramatically as an emergency, and normal tension glaucoma reminds us that optic nerve damage can occur even without elevated IOP. Recognizing these distinctions is critical for accurate diagnosis, timely intervention, and prevention of irreversible blindness. Symptom triage dashboard. Now let's focus on symptom recognition and clinical triage in glaucoma. One of the biggest challenges in glaucoma diagnosis is that symptoms vary dramatically depending on the type and stage of the disease. Some patients remain asymptomatic for years, while others present with sudden ophthalmic emergencies requiring immediate intervention. This dashboard highlights several important warning symptoms that clinicians and patients should never ignore. Let's begin with the halos around lights. Patients may describe seeing rainbow colored things, the rings around the street lights or headlights, especially at night. This symptom commonly occurs due to the corneal edema caused by sudden elevation of the IOP pressure in the acute angle closure glaucoma. When the cornea becomes swollen from pressure buildup, incoming light scatters abnormally, creating halo like visual phenomena. This is considered as an important emergency warning sign. Next is sudden severe eye pain. Think this is one of the hallmark symptoms of acute angle glaucoma, that is the acute angle closure glaucoma. So the pain in this is often intense and may be associated with headache, nausea, vomiting, and sometimes even the abdominal discomfort. Because IOP can rise extremely rapidly in angle closure attacks, immediate ophthalmologic treatment is required to prevent permanent vision loss. Now let's discuss the acute blood vision. Rapid onset blurring, particularly when associated with eye redness, halos, or pain, should always prompt urgent clinical assessment. Sudden visual deterioration may indicate dangerously elevated intraocular pressure, corneal edema, or acute optic nerve compromise. Moving to lower section, we see difficulty seeing in the dark. This symptom often develops gradually in chronic glaucoma due to progressive peripheral retinal nerve fiber loss. Patients may notice problems navigating dim environments, driving at night, or adapting to low light settings. Although subtle, this may present early functional visual field impairment. Finally, frequent spectacle prescription changes can sometimes act as subtle clue to fluctuating IOP changes. Repeated changes in vision correction may occur because the pressure fluctuations can alter the corneal curvature and refractive stability over time. Now notice the warning symbols in the dashboard. The red emergency indicators highlight the symptoms requiring urgent ophthalmic evaluation, especially sudden severe eye pain, halos around lights, and rapid blurred vision. These findings may indicate acute angle closure glaucoma, which is a true ocular emergency. In contrast, symptoms such as difficulty in dark adaptation or gradual spectacle changes are more often chronic and subtle but still clinically important. The key lesson is that the glaucoma symptoms exist on a spectrum ranging from silent chronic progression to sudden vision threatening emergencies. Recognizing early warning signs and understanding which symptoms require urgent referral can make the difference between preserved vision and irreversible blindness. Glaucoma screening and examination protocols. Let's discuss one of the most important aspects of glaucoma prevention: structured screening and comprehensive eye examination protocols. Because glaucoma often progresses silently, routine screening is essential for detecting disease before the irreversible optic nerve damage occurs. The slides divides the approach into two major components: screening intervals based on risk levels and the complete glaucoma examination checklist. Let's begin with the screening intervals. For low risk individuals, meaning the patients younger than 40 years without significant risk factors, a comprehensive eye examination is generally recommended approximately every 5 years. However, screening frequency increases when the risk factors are present. Patients with moderate risk factors such as myopia, diabetes mellitus, hypertension, or advancing age should ideally undergo eye examinations every 2 years, starting around at the age of 40. Now look at the high risk category. Patients with a strong first degree family history of glaucoma carry a dramatically increased risk, in some studies nearly 10 times higher than the general population. Additionally, high risk features include IOP greater than 21 milliliters of mercury, increased cup disc ratio above 0.6, significant myopia, long term steroid use, and previous optic nerve abnormalities. These individuals require annual glaucoma screening beginning around at the age of 40 years of age, sometimes even earlier depending on the clinical circumstances. Now let's move to the complete examination checklist used during glaucoma evaluation. The first component is tonometry. Tonometry measures the IOP, and the Goldmann Applanation tonometry remains the gold standard method for obtaining the accurate pressure readings. Since elevated IOP is one of the strongest modifiable risk factors for glaucoma progression, accurate pressure assessment is extremely important. The second component is the fundus examination. This allows direct visualization of the optic disc and the neuroretinal rim. Clinicians evaluate the cup disc ratio, asymmetry between the eyes, disc hemorrhages, and thinning of the retinal nerve fiber layers, all important indicators of glaucomatous optic neuropathy. Next is perimetry, also known as visual field testing. The Humphrey 24-2 protocol is commonly used to detect the functional visual field loss. This helps to identify the classic glaucomatous defects such as the arcuate scotomas, nasal steps, and peripheral visual field constriction. Importantly, visual field defects may appear even before the patients notice the symptoms themselves. Finally, we have the OCT, optical coherence tomography. OCT provides highly detailed imaging of the retinal nerve fiber layer and optic nerve head. It can detect the microscopic structural damage even before the significant functional visual field loss appears or develops. This makes OCT one of the most valuable tools for early glaucoma diagnosis and progression monitoring. The key lesson is that the glaucoma diagnosis depends on combining structural assessment, functional testing, and risk based screening strategies. No single test alone is sufficient. Early identification through systematic screening protocols is one of the most effective ways to prevent the irreversible blindness caused by the glaucoma. Glaucoma Pharmacopeia. Now let's move into one of the most important areas of glaucoma management, that is the pharmacological therapy. The primary goal of glaucoma treatment is simple: to reduce the IOP, to slow or to prevent the further optic nerve damage. This slide summarizes the major drug classes used in the glaucoma management along with their mechanisms, dosing patterns, and important clinical precautions. Let's begin with the prostaglandin analogs represented by Latanoprost 0.005%. These are considered first-line therapy for most patients with primary open-angle glaucoma. Prostaglandin analogs work mainly by increasing the uvoscleral outflow in aqueous humor, thereby lowering the IOP. Typically, one drop is administered once nightly, and these medications can reduce the IOP by nearly 30%, making them among the most effective topical agents available. However, an important counseling point is iris hyperpigmentation. Patients may develop gradual darkening of iris color and increased eyelash growth over time. Next are the beta blockers, such as Timolol 0.5%. These medications reduce aqueous humor production by blocking the beta receptors in the ciliary body. Timolol is commonly used as adjunct therapy and is usually administered twice daily. It can reduce the IOP by approximately 25%, but clinicians must be extremely careful in certain patients. Topical beta blockers can still produce systemic effects and should regularly be avoided in patients with asthma, severe bradycardia, chronic obstructive pulmonary disease (COPD), or congestive cardiac failure. Now let's discuss alpha 2 agonists such as Brimonidine. These agents both decrease aqueous humor production and enhance the uvoscleral outflow. An additional interesting feature is their potential neuroprotective effect, although this remains an area of ongoing research. Brimonidine is usually administered twice daily. However, it should be avoided in infants and young children because it may cause serious central nervous system depression and apnea. Next are the carbonic anhydrase inhibitors represented by the dorzolamide. These medications reduce the aqueous humor production by inhibiting the carbonic anhydrase enzymes within the ciliary epithelium. Depending on the severity, dosing may range from twice daily to three times daily. One important contraindication is sulfa allergy because these drugs are sulfonamide derivatives. Now let's discuss combination therapy and the systemic treatment. Combination eye drops such as Latanoprost plus Timolol improve the patient adherence by reducing the number of separate medications required. This is particularly important because the glaucoma treatment often continues lifelong and poor compliance is major cause of disease progression. Finally, oral acetazolamide deserves special attention. This systemic carbonic anhydrase inhibitor is mainly reserved for emergency situations such as acute angle closure glaucoma where rapid pressure reduction is needed. However, systemic adverse effects can be significant including paresthesia, metabolic acidosis, fatigue, electrolyte imbalance, and renal stool formation. The key takeaway is that the glaucoma pharmacotherapy primarily works by either decreasing the aqueous humor production, increasing aqueous drainage, or combining both mechanisms. Choosing the correct therapy requires balancing efficacy, patients' comorbidities, contraindications, and long term adherence. Because while glaucoma damage cannot be reversed, effective pressure control can dramatically slow disease progression and preserve vision for years. Surgical and laser escalation pathway. Now let's discuss what happens when medications alone are not sufficient to control glaucoma progression. This slide outlines the stepwise escalation pathway used in modern glaucoma management, moving from laser procedures to advanced surgical interventions. The overall goal remains the same throughout every stage to reduce the IOP and preserve remaining optic nerve function before irreversible blindness develops. Let's begin with step 1, selective laser trabeculoplasty or SLT. SLT is a non invasive laser procedure primarily used in primary open angle glaucoma. The laser targets pigmented cells within the trabecular meshwork, improving the aqueous humor outflow and reducing the IOP. One major advantage is that SLT is repeatable and often serves as an alternative to long term eye drops, especially in patients with poor medication adherence. On average, SLT can reduce the IOP by approximately 20 to 30%. Next is step 2, laser peripheral iridotomy, commonly abbreviated as LPI. This procedure is particularly important in angle closure glaucoma. A small opening is created in the peripheral iris using a laser, allowing the aqueous humor to bypass the pupillary block and equalize pressure between the posterior and anterior chambers. This rapidly opens the drainage angle and prevents further pressure buildup. Laser peripheral iridotomy is both therapeutic during the acute angle closure attacks and prophylactic in patients with anatomically narrow angles who are at high risk of future attacks. Now moving to step 3, minimally invasive glaucoma surgery or MIGS. So this procedure have become increasingly popular because they provide pressure reduction and with less tissue disruption and fewer complications compared to the traditional surgery. Examples include the eye stent and Kahog dual blade procedures. These surgeries are often combined with the cataract surgery and particularly useful in mild to moderate glaucoma cases. The advantage of MIGS lies in faster recovery time and improved safety profiles, although pressure reduction may be less dramatic than the traditional filtering surgery. Step 4 is trabeculectomy. This remains the gold standard surgical procedure for advanced glaucoma requiring significant IOP reduction. In this, surgeons create a new drainage pathway beneath the conjunctiva, forming a filtering bleb through which aqueous humor can exit the eye. This procedure can achieve substantial pressure lowering, but careful post-operative monitoring is essential because complications such as hypotony, bleb infection, and fibrosis may occur. Finally, step 5 includes the advanced refractory options. For patients with severe glaucoma or failed previous surgeries, glaucoma drainage devices such as MAT or bewildered tube stents may be implanted to divert the aqueous humor externally. As a last resort, cyclodestructive laser procedures may be used to reduce the aqueous humor production by partially destroying the ciliary body. These advanced interventions are generally reserved for difficult or end stage cases where conventional treatments have failed. The key message is that the glaucoma management follows a progressive escalation strategy. Treatment begins with medications and less invasive approaches or procedures, then advances step by step towards the laser and surgical procedures depending on disease severity and pressure control. Importantly, no surgical procedure restores lost vision. The purpose of intervention is preservation, protecting the remaining optic nerve function before further irreversible damage occurs. Glaucoma lifestyle modifications. Now let's talk about something many patients overlook. Lifestyle modifications in glaucoma management, while medications and surgeries are important. Daily habit can significantly influence the IOP and long-term vision preservation. First, let's look at the proven benefits. Regular aerobic exercise has been shown to reduce the IOP pressure by approximately 2 to 3 milliliters of mercury. This happens because exercise improves the blood circulation and aqueous humor drainage. However, patients should avoid sudden extreme exertion without medical advice. Next is sleep elevation, elevating the head by around 20. Many glaucoma patients experience pressure increases at night, so even a simple wedge pillow may help reduce the progression risk. Another important point is eye protection. Trauma to the eye can lead to secondary glaucoma. Patients involved in sports, construction sites, or high risk activities should wear. Now let's discuss about the hidden dangers that patients often don't realize. Head down yoga positions can dramatically increase the IOP, sometimes above 30 milliliters of mercury. These sudden spikes may worsen optic nerve damage, so such poses should generally be avoided in glaucoma. Large amounts of caffeine may cause temporary pressure elevations in susceptible individuals. Moderation is therefore recommended rather than complete avoidance. The key message: glaucoma management is not only about the eye drops or surgery. Lifestyle choices, sleep posture, exercise habits, and even daily clinical case and rapid review. Now let's apply everything we have learned to a real clinical scenario. We have a 65-year-old male patient presenting with gradual narrowing of visual fields. On examination, the cup to disc ratio is 0.8, which is significantly elevated and strongly suggests optic nerve damage. His IOP is 30 milliliters of mercury in both eyes when measured using Goldmann Applanation tonometry, the gold standard method. Visual field testing reveals an accurate scotoma, also known as Brimonidine scotoma, which is one of the classic early glaucomatous visual field defects. So, what is the most likely diagnosis? This presentation is highly consistent with primary open angle glaucoma (POAG). Why? Because the disease progression is gradual and painless. The angles remain open and there is progressive optic nerve damage with elevated IOP. Now let's discuss the first line treatment. The preferred initial therapy is prostaglandin analog, most commonly Latanoprost. These drugs are considered first line because they are highly effective, reduces the IOP by nearly 30% and require only once daily dosing, improving the patient compliance. Latanoprost works by increasing the uvoscleral outflow of aqueous humor, thereby lowering the IOP and slowing the optic nerve damage. Now let's quickly review the high yield exam points on the right side. First, remember the Goldmann Applanation tonometry is the gold standard for measuring the IOP. Air puff tonometry is mainly used for screening, not definitive diagnosis. Second, a cup to disc ratio greater than 0.6 is suspicious for glaucoma, and asymmetry between eyes greater than 0.2 is highly concerning. Third, classic visual field defects include the accurate scotoma, nasal step defects, and altitudinal defects. And finally, an important pharmacological pearl, pilocarpine is mainly used as acute angle closure glaucoma emergencies, not only POAG management because it may cause accommodative spasm and brow ache. This case perfectly summarizes the clinical diagnosis, investigation findings, and evidence based first line treatment approach for glaucoma. Glaucoma in India, a systemic and biological crisis. Now let's shift our focus to the public health perspective and understand why glaucoma is such a major challenge in India. India currently carries one of the world's largest glaucoma burdens with more than 12 million affected individuals. But the most alarming fact is that nearly 78% of the patients present only after the disease has already reached the advanced stages. Why does this happen? Because glaucoma is painless, silent, and progresses slowly over many years. Most patients do not realize that they are losing peripheral vision until irreversible optic nerve damage has already occurred. Now let's examine the biological context unique to India. India has one of the highest rates of the PACG, that is primary angle closure glaucoma in the world. This is largely due to the anatomical predisposition, especially shallower anterior chambers seen in many individuals of the Asian and Indian origin. A narrow anterior chamber angle increases the risk of sudden blockage of aqueous humor drainage, leading to dangerous rises in the IOP. But biology is the only part of the problem. There are also major systemic barriers affecting glaucoma care. One of the biggest issues is poor adherence to the therapy. Studies show that only about 32% of the patients consistently use their prescribed eye drops daily. Missing doses allows continuous optic nerve damage, which is permanent and irreversible. Cost is another major challenge. Many glaucoma medications, especially prostaglandin analogs, may cost between 200 to 500 rupees per month, making long-term treatment difficult for many families. Additionally, medication stockouts in public healthcare systems can interrupt treatment continuity and worsen the disease progression. However, there is a hope through emerging solutions. National Health Mission Blindness Control Program are improving the access to screening and surgical care, especially for economically weaker populations. At the same time, institutions like Sankara Nethralaya and Aravind Eye Care are using AI-based retinal and fundus screening system to detect glaucoma earlier, even in remote areas through telemedicine networks. So, glaucoma in India is not only a medical disease, it is also a public health, economic, and awareness challenge requiring early detection, patient education, affordable treatment, and stronger healthcare infrastructure. Final message and call to action. As we conclude, remember one powerful truth. Glaucoma steals vision silently. Most patients do not notice symptoms until permanent optic nerve damage has already occurred. But the good news is this: early detection can protect a lifetime of sight. A single comprehensive eye examination every year can identify glaucoma before vision loss becomes irreversible. This is especially important for individuals above 50 years of age, patients with diabetes, high myopia, hypertension, or a family history of glaucoma. Another critical step is treatment adherence. Patients must use their prescribed eye drops consistently and exactly as advised. Lowering the IOP remains the only scientifically proven method to slow or halt glaucoma progression. Family screening is equally important. If a first degree relative, such as a parent or sibling, has glaucoma, your risk increases nearly tenfold. That means early screening for family members can save vision before symptoms even appear. So, the final takeaway: do not wait for blurry vision, do not wait for pain. Glaucoma is silent, but blindness from glaucoma is preventable. Get screened early, stay adherent to the treatment, encourage your family members to undergo a regular eye examination. Thank you for watching. Thank you everyone for watching and being a part of this session on glaucoma, the silent thief of vision. Today we explored how glaucoma develops, why early detection is critical, and the clinical strategies used to diagnose and manage the potentially blinding disease. Remember, vision once lost from glaucoma cannot be restored, but timely screening and proper treatment can preserve sight for a lifetime. If you found this lecture useful, please like, share, and subscribe to support the channel and help spread awareness about eye health. Feel free to drop your questions or topics you would like to be covered in future lectures in the comment section below. Until next time, stay informed, stay healthy, and protect your vision. Thank you.